who is a rheumatologist and epidemiologist affiliated with the Jewish General Hospital and the Lady Davis Institute in Montreal. She's also an associate professor and member of the Division of Experimental Medicine in the Department of Medicine at McGill University. Her research focuses on systemic autoimmune rheumatic diseases. Dr. Hudson is a founding member of the Canadian Scleroderma Research Group, which has been active since 2003. The group has involved 15 sites across Canada, 20 clinicians, and 10 basic scientists. They have recruited over 1,600 patients, secured over $4 million in funding from CIHR, FRSQ, industry and patient organisations. They have trained over 30 graduate and postdoctoral students and 40 summer students. The CSRG has contributed to over 100 peer-reviewed publications and has become an internationally recognised scleroderma research program. Dr. Hudson has worked on a wide range of projects and contributed to landmark papers on health-related quality of life, disease classification, measures of disease status, renal crisis, lung disease, clinical correlates of autoantibody profiles, oral health abnormalities, and psychosocial health issues in systemic sclerosis. She has also established several international collaborations with leading scleroderma experts worldwide, such as the International Scleroderma Renal Crisis Survey, Tri-Nation Scleroderma Cohort, and International Systemic Sclerosis Inception Cohort. That one was a mouthful. Currently, she co-leads the Scleroderma Clinical Trials Consortium Working Group on Scleroderma Renal Crisis. It gives me great pleasure to welcome you today, Dr. Hudson. So thank you for joining us.
So thank you for the kind invitation. After this long introduction, I'm nothing. You know, I listen to these things and I say, is that really me? But anyways, that's not really me. I'm just going to start off by saying it's Friday night here in Quebec. And my dog is here. We're at the cottage. And there are many dogs outside. So if you hear a little bit of barking, okay, it's because it's Friday night. We're at the cottage. There you go. The other thing that I will also start off by saying is I accept this very modestly, this invitation, because you have amazing rheumatologists in Australia, many of whom I have worked with. I can only mention Mandy Nickpour, Susanna Proudman, Wendy Stevens, Laura Ross, Jenny Walker, the list goes on and on. So, you know, I feel very humbled to be invited here when I'm sure that they could do as good as a job or better than me. But, you know, it's my pleasure to be here. I will talk about something that's been of interest to me, I would say, for at least the last 10 years. And this is the whole idea of using cells, human cells, as therapeutics for scleroderma. So we all know that we all throughout our lifetime can have all sorts of injuries. We can have cuts, we can have broken bones, we can have surgery and so on. And there are cells in our body that help us repair. And so the whole idea behind this idea of cell therapies is, what are those cells that help us repair in general, in health? And can we harness those cells when there's a disease? And can we use these cells to help us repair some of the damages from disease? So that's the whole idea behind cell therapies. So next slide, please. So these are my disclosures. So I do work in collaboration with industry, and I do have funding from industry, but none of my funding to date has to do with any of my work on cell therapies. If anything, my cell therapy work has all been funded by governmental peer-reviewed grants. So next slide, please. Okay, so the first thing I want to point out is when we talk about cell therapies, there are many of these different reparative cells or cells with regenerative properties in our bodies. There are many, many of them. So far, and tonight, I will only talk about 3 of those types of cells. But we could go on and on and on. And I'd like to say that science is really advancing at a warp speed here, trying to identify many new cells that have these regenerative properties. And there are many things yet that will come out, hopefully in the next few years, that will be on this subject. But tonight I'm just going to talk about 3 of these different types of regenerative cells. Those are hematopoietic stem cells. I'm going to talk about mesenchymal stromal cells. And finally, I'll talk about CAR T cells. And I suspect many of you have started to hear about CAR T and all the enthusiasm around that. So these are the 3 cell types that I will talk about. But as I've mentioned, there are many other different cell types that could be harnessed for their regenerative properties. Next slide, please. Okay, so the first type of cell therapy that I will talk about is, again, a mouthful, hematopoietic stem cells. So I want you to forget this word, hematopoietic, because that's just a fancy word that means blood. So these are stem cells that are in our blood. And the parallel that I like to start off with by saying is sometimes people get kidney transplants, sometimes people get lung transplants, sometimes people get heart transplants. So here we're talking about transplants that involve blood cells. So they are essentially liquid transplants. So the other transplants I mentioned are solid organs. Here we're talking about liquid transplants of stem cells that have really powerful regenerative properties. So what are these blood stem cells that we can use in scleroderma? Next slide, please. So first of all, I'd like to mention that these hematopoietic stem cells, or these blood stem cells, are now a recognized therapy for scleroderma. So I'm not talking about, some abstract concept here. These are the new guidelines for the management of scleroderma. They haven't been published. They've been presented I don't remember, I think it was in Vienna in June. And so stem cell transplant has been included as a therapeutic option in scleroderma. So this is something that's available here and now. What does it entail? So next slide, please. So I usually start off with this slide, and I say, I start off by saying that where is our blood produced? Our blood is generally produced in our long bones. So what I'm showing you on the left there is a femur. It's our long bones of the leg, if you want. And in these long bones, we have our bone marrow, and the blood is produced in the bone marrow. How does this work? So I've put a box around one of these purple cells that's called the hematopoietic stem cell. So this blood stem cell. So these stem cells exist in our bone marrow. And what they do, the reason why they're called stem cells is they have tremendous potential to differentiate, and that's the property of a stem cell, is that it can become something else. It exists as a stem cell, but it can differentiate into many other cells. And the other cells that it can become red blood cells. So when we talk to our patients, you might have anemia, is because you don't have enough red blood cells. These stem cells can also differentiate into platelets. So platelets are important for clotting. We don't want to clot. But these hematopoietic stem cells also differentiate into what we often refer to as our white blood cells. And the white blood cells often represent our immune system. So they have these stem cells have tremendous properties to differentiate into very, very, very different cells, from the red blood cells, the platelets, to the white blood cells. Next slide. So among these white blood cells, what I've put a box around are the lymphocytes. So there are 2 main kinds of lymphocytes, and these are very important immune cells. So the lymphocytes are really represent the bulk of our immune system. So the lymphocytes in our immune system, often we refer to as the B and the T lymphocytes, just by reason of where they are produced, if you want. But these are the cells that we think are diseased in scleroderma. So so normally these white blood cells are meant to protect us from exterior things that might attack our body, most likely microbes. So our white blood cells will protect us from bacteria, from viruses, from protozoa, from all sorts of things. So the white blood cells protect us from the exterior. But in autoimmune diseases like scleroderma, the white blood cells turn against our cells. So, and that's why we say it's an autoimmune disease. So instead of these white blood cells defending us from something from the exterior, like a virus, they start to recognize some of our own cells. They can recognize our kidneys, our joints, our skin, and so on. So they become autoreactive white blood cells. These are not normal. We're not supposed to have white blood cells that recognize us. And that's what defines, if you want, an autoimmune disease. So the idea behind hematopoietic stem cell transplant, so I think next slide. There you go. So the idea is, what we do is we have these very precious stem cells that we know can differentiate into a normal immune system. So we harvest these stem cells, often just using an IV line in the arm. We harvest the stem cells and we put them away. And then what we do for somebody who's undergoing a hematopoietic or a blood stem cell transplant, we give that person very, very, very strong chemotherapy. And the purpose for this chemotherapy is to really remove all of these abnormal white blood cells or lymphocytes that are attacking your own body. So we give this very strong chemotherapy, but then without all those white blood cells, somebody would have no immune system, right? So what we do is then we reinfuse the stem cells that we had harvested before the chemotherapy. So we give them, the person back their own stem cells, and those stem cells can now regenerate into a normal immune system. So the whole purpose of a hematopoietic stem cell transplant is to harvest these really very important cells that can differentiate into a normal immune system. We take them out of the person. We give that person a strong chemotherapy to get rid of that abnormal immune system that they have. And then we give them back their own stem cells that regenerates or reconstitutes, we often say, into a normal immune system. So that's the whole idea behind a blood stem cell transplant. We take your own stem cells that are very precious, we put them away, we get rid of your abnormal immune system, and then we give you back your own stem cells so that you redevelop a normal immune system. Next slide, please. So what do we know? So I just told you at the beginning, I said this has been an accepted treatment for scleroderma in the past few years. So hematopoietic stem cell transplant, or this blood stem cell transplant, if you want, is the only treatment for scleroderma that has been shown to be associated with an improved survival in patients for scleroderma. There are no other treatments. This is the best treatment we have for scleroderma. And I'm not expecting you to be able to understand what the graphs I'm showing there, but what I'm showing you is patients who undergo blood stem cell transplant live longer than patients who are treated with, for example, cyclophosphamide, which is one of the more common treatments that we use for scleroderma. So it's the only treatment for scleroderma that is associated with improved survival. Next slide, please. And it's not just associated with survival, it's associated with improvement in all sorts of different other manifestations of the disease. The skin improves, the lung function improves, quality of life improves, and the list goes on. So we know that this is a beneficial treatment from the point of view of survival, but also from the point of view of organ manifestations. Next slide, please. So what I just showed you, the two studies, those two graphs that I just showed you were clinical trials. And when we find promising results in clinical trials. It's always very good and exciting. But we often also ask the next question, what about in the real world? Do these clinical trials really translate to the same benefits when they're not in the setting of a clinical trial, when they're in the setting of many different doctors, many different patients, many different hospitals, and maybe the conditions where the transplants are done are not as well controlled as they might be in a clinical trial. So the question we tried to do in some of the work that we've been doing is we've asked ourselves, do stem cell transplants in the real world work as well as in the clinical trials, as I've just shown you? So the way we went about trying to do this is, as was mentioned earlier, we have a large Canadian cohort, which actually looks very much like your Australian cohort, where there are many, many parallels there. So we have our large Canadian cohort, and in Canada, up until the last few years, we have not done many transplants. So we have not really adopted that approach. We've been a little slow, and so really our standard of care has been CellCept, cyclophosphamide, some of the other drugs that some of you might be familiar with, but we have not done a lot of transplant. Versus in France, on the right there, where France has been one of the pioneers for stem cell transplants in the world for scleroderma. So what we thought we would do is we would take our Canadian patients who would have met criteria for transplant but didn't get the transplant, and we would compare them to some French patients who did get the transplants in the real world. And before I go on and I tell you that it does work in the real world, and that will be my next slide, one of the things that I like to highlight on this slide, though, is that at that time we had 1,500 patients in our research cohort, and of those 1,500 patients, only 85 of them met transplant criteria. And I will come back to that. So yes, I just told you that this is the best treatment for scleroderma, but here what I'm also telling you is that it is reserved for only a small fraction, less than 5% of patients. And I'll come back to the reason why that is, because if it's the best treatment, why are we not using it for everybody? And the reason, I'm just going to let the cat out of the box, is that it's a toxic treatment, but we'll come back to that in a few minutes. So we had these 85 patients in Canada that were treated with standard of care, so regular drugs, versus the 41 patients in France who were treated with transplant. And what did we find? Next slide. We found exactly what the clinical trials had found, that even in the real world, when we're not dealing with, all of the strict protocols of a clinical trial, even in the real world, stem cell transplant is still associated with a survival for our scleroderma patients, compared to patients who would be treated with conventional care. That would be CellCept and cyclophosphamide, azathioprine, some of the other drugs that you're familiar. So this is really very reassuring because we see it in a trial, and now we see it in the real world. Next slide. And then we went on and we asked ourselves, so survival is one thing, but it's one thing if you survive, but if you're miserable, is it worthwhile? So we asked ourselves, what else does transplant help with? And so here, when I'm showing you, the skin scores really go down with this therapy. So by, an order of about 10 points, which is quite a lot. You would notice to have your skin improve by 10 points. Next slide. The same thing, we found that the lung function, at least early on, and even in a delayed way, lung function improves in the patients who received this stem cell transplant versus the patients who just got regular treatment. Next slide. And the other thing that was very interesting and something that hasn't been shown before, and I'm quite interested in scleroderma renal crisis, which is one of the rare complications of scleroderma. We found that the patients who were transplanted were at about a 5-time lower risk of getting a scleroderma renal crisis than the patients who were not transplanted. So really, there's a clear message here that transplant is associated with improved survival and improved organ function. Next slide. And then, it's one thing we like to look at the lung function and the skin scores and the kidney function, but what do the patients tell us? How do they feel post-transplant. And so the way we go about answering that question is we put questions to patients, and we ask the patients to report their own symptoms. And here what I'm basically showing you is we ask the patients, how was your pain post-transplant compared to regular care? How is your Raynaud's? How are your ulcers doing? How are your gastrointestinal symptoms doing? How's your shortness of breath doing? And overall, how are you doing? And what these bars going down are showing you is that the patients who get transplanted overall, with all of these symptoms, do much, much, much better than the patients who don't get who get regular care. Okay, next slide. We also ask them, how is your functioning? So there's a scale that's called the Health Assessment Questionnaire, which is really a question about how people can use their hands and how they can care for themselves and so on. So a questionnaire that goes towards function. Again, from a functional point of view, the patients in France who were transplanted were much better off than the patients in Canada who were not transplanted. Next slide. And the last thing, and this was a little bit of a surprise to me, so we asked questions about quality of life. So how is your quality of life? And often when we measure quality of life, there's two dimensions to quality of life. There's the physical quality of life, what you can do, how you can get around. There's also the mental health related quality of life, how you feel, how you function in society and so on. So on the left, which is not, there's no red box around it, from a physical point of view, from a physical quality of life point of view, our patients, the French patients were telling us that they were doing quite better. But what I've put a red box around there is from a mental health point of view. They were not, the French people, or the French patients, were not necessarily doing better from a mental health point of view than the Canadian patient. And we've reflected on this data quite a bit, and we've asked ourselves the question: they're doing better from their skin, their lungs, their GI tracts, their physical quality of life. Why is it that from a mental health point of view, they're not necessarily doing better? And one of the reasons that we've come up with, and I would be happy to hear some of your thoughts, but one of the reasons is I think that some patients in France, and now we're seeing it increasingly in Canada, who head into transplant are expecting a cure. Transplant is not a cure. Transplant will get your skin to be better, your lung function to be better, your GI tract to improve, but you still have scleroderma, so it's not a cure. And I think that this is really important information for us to communicate to our patients that we're advising to have transplant, to manage expectations. Transplant does not cure you. It really helps your disease. It alleviates a lot of the symptoms, but it's not a cure. And I think that, over time, when we get this sort of data, I use this data to really help my patients navigate the pros and the cons of going through transplant. And I tell them carefully, clearly, I'm trying to make you feel better, but this is not a cure. Next slide, please. So why are we not doing transplant for everybody? I just told you on and on that really people feel better. And the bottom line is quite simple. The actual transplant procedure, the chemotherapy that is involved with removing the abnormal immune system, that chemotherapy is very toxic. And the chemotherapy itself is associated with a risk of death in the first 100 days of about 5 to 10%. So when I explain transplant to my patients, I ask them to try to wrap their heads around that yes, you have scleroderma. Yes, your life expectancy is reduced, but you still have many years ahead of you, that you're not going anywhere anytime soon. But just from the procedure of transplant, your risk of death in the next 3 months is 10%. And that's not negligible. And often I'll tell you from my experience, patients see this in different ways. I have the patients who want the best. They want the best, and they are risk takers, and they say, I don't care about the risk. I want the best. If you tell me this is the best, I want this procedure. That's some types of patients that I see. And then again, I see the other type of patients who are who are quite risk averse. And I like to talk about this young woman who is about 45 years old. And she said, I have a 10-year-old at home. And you're telling me that my risk of death in the next 3 months is 10%? That's a no-go for me. Okay, so transplant is not an easy decision. It's a complicated decision. It has to be restricted to people who are sick but not too sick, and people who are willing to take that short-term risk of death that's associated with the procedure, not with the disease, with the procedure. So that's the reason why I showed you before that out of our Canadian cohort of 1,500 patients, there were only about 5% of them that were eligible for this treatment. It's because this treatment is only reserved for a really restricted group of people where we think that the risks are outweighed by the benefits. And that's really a small fraction of our patients. So next slide, please. So I can just speak to our local experience. So most of our transplants are done in Ottawa, in Ontario. And you can see that some of the pioneers here in Canada were slow to take this up. But, you know, the second large trial that I mentioned was published in 2018. So you can see that already in 2018, we're starting to see more transplants. In 2019, it was really taking off. And then next slide. What happened in 2020 was that COVID hit, and because of the risks of infections associated with transplant, there was a big drop in the rates of transplant, but slowly we're picking up. But really, you know, if you look, we're talking about 10, 12 patients in Eastern Canada, if you want, that get transplanted a year, and there's a site in Western Canada. So we're talking about, you know, 20, 25 patients a year who are being transplanted in Canada. That's a fraction of our scleroderma population. So really, this is a treatment that's really reserved for a very select group of scleroderma patients. Next slide. So in summary, for these blood stem cell transplants, they're associated with better survival, better physical health. As I mentioned, there's no effect on mental health, but they are associated with a high risk of treatment-related mortality in the order of 5 to 10%. This is early mortality, and therefore they're reserved for a very small fraction of patients. Next slide. So having said that, this is in the guidelines. This is an option. This is a therapeutic that I do discuss with my patients on occasion, but this is not the solution for most of the other 95% of our scleroderma patients. So there's an urgent need for us to identify safer treatments. Next slide. So that brings me to the second type. So we talked about the blood stem cells. So now we're going to talk about a second type of cell therapy that are called mesenchymal stromal cells, so MSCs. So next slide, please. Okay, so you've seen this slide before. I've told you that in our bone marrow, our blood cells, our circulating blood cells, are produced in the bone marrow. And as there was more and more research going on, there was this discovery about all of these. If you look on the left lower quadrant of this slide, you can see in purple, the stem cells, but you can see all these green cells that surround the stem cells. Next slide. So these are what we call stromal cells. So these are the cells that were discovered initially in the bone marrow that support, that nourish, that keep those very precious blood stem cells healthy. These are the mesenchymal stromal cells that I'm going to talk about. Next slide, please. So these cells were initially identified in the bone marrow, and their first role that was discovered was to support these blood stem cells that we've been talking so far. Next slide. But over time, you know, people were really interested in these stromal cells that are also in the bone marrow. And these cells were found to have many regenerative properties. These regenerative properties include, among other things, they are antifibrotic, they are pro-angiogenic, and they keep the immune system under control. They are immunomodulatory, okay? So these are really regenerative cells that repair things that go wrong in our body. So some very smart people looked at this and said, well, you know, in scleroderma, the things that go wrong in scleroderma, there are 3 things that go wrong in scleroderma. There's fibrosis, there's problems with the circulation, so vasculopathy, and there's immune activation. So somebody said, well, wouldn't it, these stromal cells seem to reverse the fibrosis, the vasculopathy, and the immune activation? Is there a potential to harvest these cells, which are different from the purple cells that I showed before? So do these cells have a potential for regenerative property, and especially in a disease like scleroderma? Next slide, please. So the other thing that also, as research was progressing, initially these cells were identified in the bone marrow as people were investigating the blood stem cells. Next slide. But then it turns out that these cells, these mesenchymal stromal cells that have this nourishing properties, they exist everywhere in your body. We have them everywhere because we need to repair all sorts of different tissues when there's an accident, a break, or whatever. So these stromal cells, which have these regenerative properties, were found to be plentiful in adipose tissue, which is essentially fat. And they were also found to be very, very plentiful in Wharton's jelly. And Wharton's jelly is essentially an umbilical cord. Okay, next slide. So the nice thing about this type of cell, if we could harvest them and if we could infuse them into patients to test if they have these regenerative properties, is these cells do not require any chemotherapy. So I told you that the toxicity of the blood stem cells is all related to the chemotherapy and all the acute risks of infections and so on when you get a stem cell transplant. Here, these cells, the way I sort of describe infusing these cells is essentially like a blood transfusion. People get red blood cells from a donor. People get platelets from a donor. People get all sorts of blood products from donors. These are cells that we can get from donors and we can reinfuse into a patient without needing any chemotherapy, okay? And so the idea is if they have all these amazing regenerative properties, can we reinfuse them without the toxicity of the chemotherapy that is needed with the stem cell transplants that I mentioned earlier? Next slide. So far, there's been one study in scleroderma. Now, you have to understand these cells have been studied in many, many, many different settings because they have this strong potential for regeneration. But in scleroderma to date, there's been one study, and it's a study out of France with some of our collaborators. And in this case, they took the stromal cells from donors who were either related or friends of scleroderma patients, and these donors underwent bone marrow biopsies. So this is quite invasive, okay? I don't know if you're familiar with bone marrow biopsies, but it takes a big needle that goes into your hip, and they try to suck out as much blood as they can and to get some of these cells. So, but you can imagine that if you asked your husband or your friend or your sister or brother, they would probably accept to do this. So in this case, they had 20 scleroderma patients, and these 20 scleroderma patients had identified 20 donors who were relatives and friends and so on. And from these donors, they were able to get from their bone marrows some of these stromal cells that were reinfused into the patient. And what I'm essentially showing on this slide is after one infusion on the top, there was a very nice improvement in the skin score. And on the bottom, what I'm showing is there was a very nice stabilization in the lung function at 1 year. So this is the first small signal that we have in scleroderma that these stromal cells might be beneficial. So what we've decided, what we went on to do, and every time there's one a study in medical science, that it always prompts more questions, and then you have to go to the next study and the next study. So building on this study, next slide, what we decided to do is we decided to also look at the potential of these stromal cells in scleroderma, but we decided to innovate slightly. So first of all, in the study that I showed you just before, it was an open label study. All of the patients knew that they were getting the infusions, and the physicians knew that all of the patients were getting the infusions. And I often say that human nature being what it is, patients would like to think that they're getting better, and doctors sure like to think that their patients are getting better. So one of the questions when you do an open label study is it really working, or is it really just human nature sort of making you think that the skin looks a little softer and so on? So in our study, what's different from the previous study is we're doing a blinded placebo-controlled study. So some patients are getting the cells and some patients are getting placebo. And at the end, if we see an effect, we know that it's over and above just human nature, and we think that it's really a beneficial effect of the cell. The second thing that we've innovated, as I mentioned in the previous study, it required bone marrow biopsies from relatives and friends. And as I mentioned, these stromal cells are plentiful in umbilical cords, and most umbilical cords get thrown out. So we were able to harvest one umbilical cord, and from that one umbilical cord, it doesn't take any biopsies from anybody. We're able to harvest all of these cells in the billions of numbers. And then the third thing that our study is a little bit different is that, as I showed you with the previous study, they did one infusion of these cells and saw a very rapid improvement in skin softening. So what we're doing in this study is we're actually giving a second infusion at 3 months to see, can we even make the skin look even better than with the previous study. So this study of mesenchymal stromal cell is ongoing. We are trying to recruit 18 patients, and we've already recruited 9 and treated 9 patients. So we're about halfway there. And I think that, I think that we're hoping to demonstrate that what we see in the lab, this therapeutic or regenerative potential of these cells, might actually be able to be translated into real therapy in patients. Next slide. So for the summary for mesenchymal stromal cells, the trial is ongoing. I think it's wide open. It's premature to be able to say one way or another, but that's where we're heading. Next slide. So the third type of cells that I will talk about are the CAR T cells, and I'm sure some of you have heard about CAR T cells. So next slide. And when I start to try to talk about CAR T cells to physicians and even more maybe to patients, I say, oh, this is really hard to explain. So I'm going to try to explain what CAR T cells are. So the first thing is, what does CAR stand for? It's a chimeric antigen receptor. So I asked myself, what is a chimera? So I went to Wikipedia, and a chimera is really, this animal from Greek mythology that is a hybrid. So that's the operative word that I want you to remember when you think of CAR Ts. Okay, so the chimera was a hybrid between a lion and a goat. So it's two different things that are not supposed to be together that are together. That's what a chimera is. Okay, so next slide. So the whole idea of CAR T comes from the cancer field. And I often say that the cancer researchers are light years ahead of us, but in a sense, that's a good thing because they also give us some pretty good ideas. So the idea of CAR Ts, what I'm showing at the top here, is that in a person who has cancer, that cancer cell expresses abnormal proteins. Those abnormal proteins are called antigens. Next slide. So what some really amazing scientists did, they said, normally our own T cells, I talked about the T cells at the beginning, a normal, healthy immune system has lots of T cells to defend us against all sorts of abnormalities in our body. So these scientists said, what if we took that person's T cells and we made it express a receptor? And the way they do this is they infect the T cell with a virus, and that virus, by infecting the T cell, also has the message to express a new receptor that normally the T cell doesn't express. And so this is the chimera. This is the person's own healthy T cells that now also expresses a receptor, and that receptor is meant to recognize this abnormal cell. So next slide. So the way it works is it's the person's own T cells, own healthy T cells that are meant to defend ourselves against external stuff. And here that T cell has been genetically modified to express a new receptor that it's not supposed to express. So that's the hybrid here. But that receptor is meant to recognize some of the proteins on the cancer cells and destroy the cancer cells. Does this work in cancer? It works amazingly. There are some cancers that had 6-month survival rates. There were absolutely no treatments that now have long-term remission rates. In some of these cancers, people are actually talking about cures. Okay, so a few years ago, these were cancers that were lethal, that for which there were absolutely no treatments, and they were rapidly progressive. And now people are talking about manipulating the immune system to express these receptors that can actually kill cancer cells and that can cure the cancers. Next slide, please. So then people well, how does this work? Okay, sorry. So here I'm going to tell you. So this is a bit of in between the stem cell transplant that I first talked about that takes a lot of chemotherapy, the stromal cells that I just mentioned second that takes no chemotherapy. So when you do CAR T cells, you need some chemotherapy. Okay, so what it involves again putting an IV line in the person, harvesting that person's own T cells, genetically modifying those T cells, then expanding them in a lab somewhere, it's really complicated, and then eventually reinfusing those T cells that now express these receptors, and then reinfusing those cells into the person so that those cells can kill off, that receptor can recognize abnormal proteins in the body and kill those abnormal proteins. So in order to do this process, you need some chemotherapy. So it's not the strong one that I talked about, but you do need some chemotherapy. So next slide, please. So as I mentioned, in some of the hematological malignancies in particular, we're talking about cure. So mostly this has been led for the autoimmune diseases by people in Germany. And so the German people said, well, if you can get rid of cancer cells, can you get rid of abnormal lymphocytes that drive autoimmune diseases? So they asked the question, can we use these same cells and try to treat diseases like lupus, myositis, and scleroderma? Next slide. So this paper was published earlier this year, and there was a tidal wave that went through the world, where people said, this is amazing. What I'm trying to show here, so at the top, there are 15 numbers there. Those represent 15 patients. The first 1 to 8 represent lupus patients. 9 to 11 represent 3 myositis patients, but 12 to 15 represent 4 scleroderma patients. What the graphs at the bottom really show is that for lupus, and we know that B cells, so these CAR T cells really target B cells. In lupus, it works amazingly. So the results are really quite dramatic. For the myositis patients, the results are very promising, but there's only 3 patients here. And then for the 4 patients with scleroderma, which are on the right side here, what they show in this paper was that the skin scores really improved quite a bit, and the disease activity scores improved quite a bit. But, I need to temper everybody's enthusiasm here by saying we're talking about 4 patients here. And often, again, scientists like to report their successes, and they're a little bit more, they don't always report their failures. So this is very promising, but this is just on a few patients. Next slide. So basically, with the CAR T cells, with the blood stem cells that I mentioned earlier, the mesenchymal stromal cells, and now the CAR T cells, we are really living through the cell therapy revolution. And again, what I mean by that is there are cells in our body that have these regenerative properties, and can we harvest these cells to try to repair some of the problems that happen in people with diseases. So there are now increasingly a lot of studies looking at the potential of cell therapies to treat autoimmune diseases. Next slide. But for every, study out there, or for every patient that gets reported as potentially having improved with these cells, there's a whole bunch of questions. The question, and the questions I've listed there in scleroderma in particular, but there are many questions for other diseases. Who are we going to give this to? Are we going to give this to patients who would be eligible for stem cell transplant, the first therapy that I mentioned, because we know it works? Or do we, so it's not clear who are going to be the best subjects for this. I've been talking about CAR T cells, but now there are other cells in our body, NK cells, Treg cells, and engineers are trying to engineer all sorts of new cell therapies. I mentioned the receptors, and the current receptors that are being used, that little yellow molecule that I showed on the T cell is mostly a CD19 receptor, but there are many, many other receptors that we could be using. And perhaps some of those receptors would be more specific for scleroderma. So there's lots of work there. What's the dose? How much chemo? What's the long-term effect? Maybe the data that I just showed you from that paper was really over the first year. Is this sustained? In the cancers, it's sustained over many years, but we have no data in autoimmune diseases. So we're still really at the beginning of trying to understand how these different cell therapies will work. Next slide. So here I'd just like to point out, I'm sure in Australia these networks are starting up, but we have started our own CAR T cell network. Nancy Maltese on the right is one of my students, and we're working with two hematologists, one in Ottawa and one in Vancouver, in trying to bring CAR T cells to the bedside for our patients. And so we're hoping that, if we're lucky, this is something that we could offer our patients in the near future. Next slide. So the summary for CAR T cells is very, very promising. There's lots of really interesting science that's going on, but I think it's really premature to conclude anything one way or another, and especially for a disease like scleroderma, which among all of the rheumatic diseases that we have is often the one that's the hardest to treat. Next slide. So that's it. In conclusion, I'd like to say, cell therapies, I hope that I've opened your eyes to an alternative way of trying to treat scleroderma. I think that hematopoietic stem cell, I say it's of the past, and I only mean it's in the past because it's been demonstrated to work. So we do have one cell therapy for scleroderma. I think mesenchymal stromal cells are the present. We are trying to investigate their therapeutic potential for scleroderma. And then potentially some other cell therapies like CAR T are the potential future therapies for scleroderma. So with that, I'm going to say thank you, and I'm happy to answer some questions.